Thank you very much, Roxanne. And once again, I want to say this again. It was indeed a very inspiring morning. And Alan, you may not remember, but I do remember that almost 20 years ago at the Euro PCR meeting, after you presented your first case in the Bordeaux room, I came up to you and shook your hands, and you said, "You're from Cedars." And you said, "My heart is at Cedars." So I always like to say that story. Uh, all right, terrific. So I'm going to talk a little bit about TAVR and aortic insufficiency, and there's a lot of aortic insufficiency. If you look at some of these prevalent studies, almost 2% of patients actually, especially when they're older, will have aortic insufficiency. And what we also know is that when they're managed conservatively, their outcomes are not good. Their survival is actually much poorer compared to what is actually expected. And what we also know is that, in fact, the survival gets worse when patients have increasing NYHA class. So in fact, indeed, an indication that we should be intervening, in fact, earlier in some of these patients. And that's shown here in this surgical series, where actually patients who were operated when their NYHA was class 1 or class 2 actually did much better than patients who were actually class 3 or class 4. Now, so, looking at the most recent guidelines, there is no mention of TAVR. So I just want to be very clear that there's actually no mention of TAVR in ACC/AHA guidelines. In fact, the only mention about TAVR is right there at the very bottom when you say it's class 3. So in patients who have isolated severe AR and who are surgical candidates, it's actually contraindicated. So I think that's how I want to start this conversation. Now, let's see. So, but nonetheless, there is quite a bit of interest. And if you look at some of this published series, there are quite a few of them talking about TAVR and aortic regurgitation. But the obvious challenges are, large annuli, insufficient anchoring, which results in dislocation and embolization, residual AR. And I think often in an attempt to anchor, we actually overstretch and actually cause annular rupture. So I think these are the obvious issues. And I think talking about aortic regurgitation, the important thing is, how do you anchor the valve? Do you anchor at the annulus and the aorta, the annulus alone, and the leaflet plus annulus? And there are a number of these devices that I've actually shown there. And I think the best way to anchor this may indeed be at the leaflets in addition to the annulus. And that's where the Jenna valve is actually an important device. And these are some of the earlier series that actually showed that the outcomes were not very good. In fact, if you look at some of the results here, you're looking at second THV required in almost 20% of the cases. There was a small series with the accurate valve, and in fact, the outcomes didn't look all that bad, but there's actually been no further work on that. And this is the study from the TVT registry. And what you see here is that compared to aortic stenosis, when you look at TAVR for aortic regurgitation, there was higher device migration and embolization, higher rate of reintervention, higher conversion rate to surgery, and 30-day mortality rate was 15.5%. And we looked at a series as well. One of our associates, Dr. Sanghan, actually gathered more than 300 patients from different sites. And essentially, what we showed was that the mortality at 30 days was 9.4%. What we also, and this was in patients where the STS score was 6.7%. So we're all used to seeing O to E ratios less than 1 when we talk about TAVR, almost half. But here, once again, as you look at it, the 30-day mortality ratio, even with the newer generation devices, was in fact more than what was the STS score. And also, patients who had residual aortic regurgitation did worse than patients who had no residual aortic regurgitation. So I'll just show you a couple of few case examples. Here is one, patient with severe aortic regurgitation. As you can see, absolutely zero calcium. And here is a case example using the Evolute valve. And we actually got a very nice result. So I think these cases are being done around the country, around the world, with actually not bad outcomes. Here is a case that Eberhard talked about when he was at a hospital. This is almost 8 years ago. This is a 50-year-old patient who had prior surgery on his valve. And in fact, we did a core valve, as you can actually see, which then slid down, and then we snared the valve up and then went ahead and put a sapien in there. You can see it's the XT valve. But this patient did remarkably well. Has no aortic regurgitation. He actually was taken off the heart transplant list, which was where he was before we considered him for TAVR. And he's doing well, 7 years out, in fact. And the other thing that I wanted to point out is this patient had quite a bit of mitral regurgitation. So once you fix aortic regurgitation, you can see what happens to mitral regurgitation in 3 months. So I think this is the issue, right? Commonly, not uncommon to have AR and MR. I think it makes sense to fix AR first in a lot of these cases. And here is yet another case example where the annulus is 595, and we in fact take 5 extra cc's and go ahead and actually deploy this valve, and this patient did well. And here is a patient with previous David procedure, and you can see this patient had aortic dissection, but we were able to go through these endograft and go ahead and actually deploy this valve. So and this is a patient now. There is no leak, as you can see here, and I will show you the outcome actually a year later. You can see there is no residual regurgitation, and the patient has actually done well. So we can do these cases, but it depends upon the anatomy. The important thing is to talk about this new valve, the trilogy, the Jenna valve, and essentially it's a nitinol frame with porcine pericardial. But the most important feature is these locators, essentially, which help anchoring the valve on the leaflets in addition to the annulus. And there is this large opening which allows the easy access to the coronary arteries. And because of the way it is deployed, there is actually naturally, the valve is aligned with the commissures. So, it's available in 3 different sizes. It's a valve that is introduced through a long sheath, which actually reaches almost up to the sinotubular junction. And here is a case example of a patient who's got severe aortic insufficiency that we enrolled in the Align AR study, and once again showing no calcium here, and essentially what you're doing is you're releasing these locators, and then you're injecting selectively in each cusp to make sure that the locators are there. This can also be guided by TEE so that you can actually see how the valve aligns and where the locators are. And then the valve is actually released. So you can see the valve sitting very nicely. And this is no significant residual aortic regurgitation. Now, in fact, we recently did a live case for the TCT. So for those of you who are interested, you can actually go and watch this live case on TCT Connect. So what are the data? So this trial is ongoing right now. It's a multi-center, single-arm prospective registry in patients who are high risk for aortic regurgitation, essentially. And these are all the different sites. Torsten is the study principal investigator. Now we have done at Cedars close to 30 patients in this study. And if you look at the outcomes that were reported by Torsten at the ACC last year, in patients where the average age was 74 years, the outcomes were actually not bad. The device time here was 26 minutes, as you can see. Absence of procedural mortality, 97.1%. There was one device embolization. And if you look at all-cause mortality at 30 days, it was actually 2.9%. And here is the pacemaker. So the pacemaker rates are a little bit higher, or they were higher. They've actually come down now, since we've realized that we don't need to be pushing the valve too low. And I think also in terms of sizing, we've made some adjustments. So I think they are still hovering around 15-17%, and this is something that we'll have to continue to work. What is also very important is, in addition to the elimination of aortic regurgitation and low rates of PVLs, if you look at the effective orifice areas, they're actually quite large, 2.7, and the gradients are actually very low. So I think there is the supraannular design, and the way this valve is designed with commissural alignment results in very good hemodynamics. And also, these are the impacts on the NYHA class, which seem to be quite good. So I think, so I've shown you some examples. Aortic regurgitation prevalence is significant. I think we are all underestimating and undertreating patients in our cath labs and in our clinics. The published outcomes of TAVR by current commercial self-expanding and balloon expandable devices, they are less than ideal. But I think we've also learned, and I think we are picking better patients. So I think there needs to be another analysis on the use of these devices. Treatment of pure aortic regurgitation, I think, would be best served by devices that anchor both at leaflets as well as at the annulus. And the Jenna valve trial is ongoing. The initial results are promising, but let's wait and see. And as was mentioned earlier, this device is already approved for commercial use in Europe. Thank you.